Hey, hello, and welcome to our webinar, Cost Report Complacency, the Downstream Financial Effects to Medicare Cost Reporting. I will turn it over to our speakers, FinThrive's Jonathan Wick, Vice President of Healthcare Insights, and Amber Baker, Solution Strategy Director. Jonathan, Amber, the floor is yours.
Great. Thank you so much, Becky, and good morning or good afternoon to those on the phone. Amber and I are elated to talk to you about a fairly dry subject of cost reports, but we'll try to make it as fun and as exciting as we can. I know this is a subject that Amber is very passionate about, and she's one of my favorite people at FinThrive in terms of her expertise and ability to have interaction with you all in terms of things that we can do to improve your financial position through this. Basically, we're going to go through, market forces. I'll take that piece and talk through, what's going on for my cash position right now with the rating agencies and how, through the CFO lens, really we're looking at the acute hospital and health system market and just some headwinds and tailwinds that we're seeing there. We'll talk a little bit about some of the challenges from Medicare and the Centers for Medicare and Medicaid Services from a puzzle standpoint. And then I'm going to turn it over to the expert. I'm going to try to stay out of her way today. And Amber's going to talk through some of the things that FinThrive is doing in the market to really help folks maximize their revenue from those finicky little government payers that are out there. So that's kind of our agenda today. We'll dive right in. Let's talk market forces here for a minute. This survey just came out of Becker's, and I pulled it. I thought it was great. It talked about financial stability as being the number one focus right now for hospitals. And I've been doing this a while. I started as a hospital transporter, was a chief revenue officer for a few years, and I've been on the tech side here for almost a decade, and I miss the hospitals, but what I don't miss is budget season or when things kind of troughed out. And I would argue that COVID and the wake of COVID really caused probably one of the worst financial years that healthcare has seen since its history. 21 and 22 were really trough years where after the CARES funding kind of exhausted and some other things, really had to get negative margins shifting into a positive place. Forvis Bazaars, who put this survey together, echoes that sentiment from executives in finance that stability is the number one issue facing hospitals right now. And what I liked seeing is that revenue cycle represented as one of the strategies to get there. And so Amber and I are going to really focus in on the finance side of revenue cycle. I've got some slides here in a minute that are going to talk about how the kind of the finance controlling treasury side of the business doesn't interact at the level that we would like it to as much with the revenue cycle level activities and operations. From a bad debt reporting, self-pay charity, clearance, kind of collaborative thing. I think the cost report kind of lives in its own little cave. And once a year, the bear comes out of the cave and kind of talks to revenue cycle and says, hey, this is what we're doing. And then revenue cycle goes back to turning and burning with patient accounts. And maybe I'm wrong, correct me if that's it, but that's how it was at my hospital. Most of the hospitals that I talk to is that relationship's not quite as tight as we would like. I sat in on Fitch's not-for-profit sector outlook last week, and this is a slide from there. Kevin Holler and I know each other, and they talked about these core credit drivers, and I want to talk about the credit position of hospitals and health systems today. Really seeing labor costs, availability, and non-labor operating costs go down, and that's why I think you're seeing the market move. All three credit rating agencies have moved the market from negative, or Fitch calls it deteriorating, to stable. That's the first time I've seen that in a few years where all three are, one, doing the same thing, and two, they're all positive. Now, downgrades are still happening at a rate probably higher than folks would like. And those of you on the phone are obviously finance professionals, so I don't have to talk through the importance of bond ratings and how that impacts your ability to borrow and your borrowing expense and what that looks like from a cash flow perspective. But my point is that you're seeing a general positive trend. Kaufman Hall releases a hospital flash report every month. This is the December report, which just came out this week, actually. And I wouldn't get too hung up on that November 3.3% there. This is an index that's variable that actually adjusts every month, and so it kind of goes back. I think you're going to see a number at 4.5%, 5% for November. But my point is that we are well into margin proficiency as we move forward, where we're at. And on that Fitch Outlook call that I had, that I sat in on, Kevin and the analysts on there talked about this trifurcation concept, which I really like. And as Amber and I are talking today, we really want to talk about kind of getting your altitude up, like getting the cash yield back to you and getting credit for the carrier providing, be that from Dish, Medicare beneficiary bad debt, your IME, GME, shadow billing, those types of things, making sure that you're getting every last dollar. When I worked at the hospital, and Amber will echo this, Medicare does not pick up the phone and call you and say, hey, you know what? We think you need more money. We think that you didn't really report right and should adjust your cost report because it doesn't look right to us. That preponderance of being accurate and thorough, and I would argue efficient, is left to the hospital. What Amber and I are seeing, and she'll draw into that a little bit more as an expert, is what's good enough for what's happening in the traditional way is not getting to this upper echelon, and it follows what Fitch is saying here too. From a bond rating standpoint, which really is a function of the financial health of the organization, if you're in that green area, you're doing the same things, which is great. It's better than going down, but you need to move up. You need to become stronger as an organization, and they're showing that from this rating standpoint. And I would argue organizations that have an effective cost reporting strategy and are managing their government reimbursement in a way that's effective using third-party technologies and expertise like we're going to show you, are going to be ones that have that higher altitude we talked about moving forward. That said, this is definitive data here showing the tranches. This is about 6 to 18 months old, depending on where they're at, but we ran some data at FinThrive just on flat margins, whether the operating margin is positive or negative. And it's important to understand, if you go back to like this trifurcation, where are you as an organization? Are you in that middle, upper, or lower? If you're in the lower, it's absolutely critical to optimize your cost reporting. If you're in that middle area, you want to make sure that you're getting positive outcomes and capture of those things. There are many, many hospitals I've talked to that live or die on Dish, in terms of making sure that reporting is there. Most of the hospitals that Amber and I talked to are getting some proportion of the Medicare beneficiary bad debt, but there's always opportunity to get at that as they move forward. Moody's put together this median hospital metric slide, which I love, talks about key financial metrics. Cash obviously bled out a little bit during the wake of COVID in 22 and 23. I think we're going to see that come back up to the 200, 215, 220 range in 24 and 25. Cash to debt ratios, operating margin, as I mentioned, operating cash flow, and debt to cash are all greatly improving as we move forward. We're seeing a general stabilization in the market, which is good. So hospitals are going to move from kind of this sustainment to growth. And when you're doing that, it's tremendously important to optimize your cost reporting strategy, and we'll talk about that today. Another look here from S&P, days cash, margins are 1.1 here. As you saw from Kaufman Hall, that index is running around 4. You'll see some things from Fitch here in a minute that are predicting probably around 6%, which I think would be awesome, and most of us would love to get to that level. As I mentioned, the market is really stabilized. We're seeing labor expense continue to level out, as you saw from that Outlook report. Balance sheets are benefiting from that. Forecast median operating margins between 1 and 2%, barring any issues to the system. This came from their Outlook report. They did couch a little bit of these forecasts surrounding the administration. FinThrive will be putting on some legislative updates this year. I'll get with Becky if we feel like that's worthy of doing a webinar back out to you all. Please comment in the comments and things if you feel you'd like to hear that. But I do one for our business. I've done it for organizations like HFMA and KHAM and AHAM and others to talk through what we think that economic impact of the Trump administration, Doge, Dr. Oz, Elon Musk, and the other folks that have been headed up with the cabinet, the Help Committee, the Ways and Means committees, what we think might happen to Medicare going forward in terms of reform and some level of defunding as well. S&P looked at the hospital outlook, and as I mentioned, they raised that from negative to stable. They kind of highlighted this area of cash flow and capital and the ability of organizations to capitalize, for lack of a better word, on that cash position and really look at their reserves. Health policy is certainly coming. We're going to look at that and see how that looks as we move forward. Payers, they remain difficult. Now, S&P said that they're seeing favorable contracts occur. I got to go research that because last I checked, payers are playing pretty hard ball. They are denying a lot of things. They are, especially on the commercial side, Medicare Advantage has a multiple of denials over traditional Medicare. We'll talk through that here in a minute as well. And as I mentioned, those underpayments are occurring. Unexpected challenges. I think you're going to see more cybersecurity investment happening. FinThrive's investing a lot there. You're going to see plant and investment growth. I think M&A activity is going to probably prosper a little bit as we move forward into 2025 as the legislation changes. Some of that oversight might be lightened up as we move. Moody's looked at this as well. They said that the labor and cost inflation that's plagued hospitals has leveled out. Supply costs, unfortunately, for the wage index and some of the inflationary things that have occurred are going to stay where they're at. But that still is being overshadowed, and I would argue outpaced by the strong operating cash flow that we've seen. Moody's is much more favorable than Fitch here, saying that of their block, they expect margin improvement 7% as a 1% percentage increase over last year, which I think is great. They expect growth as hospitals increase their cash flow. 60% of hospitals are expected to have a 6% or more margin. That's way inflated from the other areas I've seen, but I think that's positive news for the market. They expect, as I mentioned, higher reimbursement from the commercial insurers as well. And they expect some investment in cybersecurity to make sure that hospitals are staying resilient, have redundant processes in place, and are looking to make sure that they're protected from operational things. Moody's also had this in their comments, which I thought was great. They talked about strategic alliances with companies that specialize in revenue cycle, and that's certainly FinThrive for that matter, and really want to drive down their costs, maximize their yield, allowing them to approach this financial stability, which I think is super important as you're looking at your cost reporting strategy. I'm going to dive in now to kind of specifically Medicare and cost report elements, now that I've given you kind of a market update, which is mostly positive. I actually was pleased to put those slides together and kind of pass along that information. We're seeing generally at FinThrive in the base, we're installed in roughly 2/3 of the market in terms of hospitals. CFOs we're talking about are fairly aligned on these four elements. Every time we're interacting with the C-suite or with stakeholders as an organization, FinThrive has this conversation that hits these pillars of what are your missions and goals? What challenges are you seeing? What strategic objectives do you have this year, and how can we help you get there? And what business priorities do you have? And are there things in our playbook, in our wheelhouse, that we can effectuate positive financial change for your organization in terms of what we're doing? I'm seeing the CFO role significantly transition from transition and accounting to more of a strategic type role. More hands-on the operations, understanding some of the things Amber's going to talk about in terms of what needs to happen strategically to maximize yield, specifically as it relates to the cost report. Something we also see when we're talking to our customers is really this financial blame that's occurring. And we see, as I mentioned, that bear kind of coming out of hibernation and us looking at opportunities is Well, revenue cycle captures that. We don't. We kind of have to report based off what the documentation is and billing. And then the revenue cycle will go, well, hey, I'm not involved in the cost report. We're just basically admitting patients to the hospital, scheduling them, doing financial clearance. And they don't understand the value of the audit necessarily. And I would argue they're not staffed for it either. Most revenue cycles, even mine, was staffed to keep the lights on. We were there to turn and burn patients, admit, register, schedule, answer the phone, submit claims. And when anything else kind of happened, we'd have to take someone off of that. We did not have flex staffing available for us to go help the accounting department or the controller figure out what needs to be reported. Typically, a request came in, we turned that report around and we moved. When the auditors were on site, that was typically something that happened with the CFO. And so this blame game happens. It's not bad. I just think it's different priorities, different incentives, those types of things. Oops, hang on, I'm stuck. There we go. So this results in this poor communication. And I think disaligned incentives and really this lack of teamwork sometimes, because there's often this abyss, I would say, this invisible Chinese firewall, if you will, between the business office and the Treasury Department. The CFO has to look at that very closely from an org chart standpoint, operationally and strategically, looking at the business office and the finance department as one, making sure that director of billing is talking to the director of reimbursement, and they're understanding how reporting of Medicare beneficiary bad debt impacts the cost report, and how that ATB needs to accurately reflect copay, coinsurance, and deductible dollars in the right way as those reimbursements come in, so we can understand that dunning cycle and how those letters go out the door so that on audit, that can be defended, right? And that makes it challenging. Without software, I would argue, or technology, it's very difficult to make sure that those bad debt logs, those dish logs, all of those things are at a level. When we go into hospitals, and Amber will be able to amplify this more than I can, we often find a delta between what they're finding and what we found, and we get them there through our solutions. Achieving best practice absolutely requires collaboration across these two entities. Between the finance and the business office, we need to be able to get to best practices. The data needs to be agreed upon. Those logs need to be accurate, timely, and completed in a manner that will be defended upon audit. We're very proud at FinThrive of our defendability, and we've done a very good job there, and Amber could share some details in that area. I'm going to turn it over to Amber now into this cost reporting puzzle, I think. All right, yeah, and she's going to talk through what things we are doing at FinThrive and how we're making a difference with our customers. I give you the illustrious Amber Baker.
Thank you, Jonathan. Yeah, we are seeing more and more of this charity puzzle, and it's literally looks like the screen, a bunch of different puzzle pieces, and it's not a one size fits all and cookie cutter for reimbursement for each hospital. You have so many different variables that are in play, whether that's hospital rules, hospital policies that are changing, state-specific policies that are changing, areas where you used to be able to access data, you can't access those data sets anymore. Or, Jonathan's been with the hospital for 30 years and his tribal knowledge is all in his head. And now you're starting to see more and more of that population actually look at a retirement plan, and there's no contingency there on bringing in some of the younger generation and getting them trained up. It's hard. The puzzle of hospital reimbursement in general is hard, and then you throw in the government, and it just completely complicates everything, that much more. And so really, when you're looking at, how do we do this going forward? You have to be able to figure out how to put those puzzle pieces together, and you have to be able to do that outside of the box. And sometimes that is having some internal folks that can put parts of the pieces together, using technology that can help with other pieces of that puzzle. And then in a lot of cases, it's the combination of the two that really complement each other. But it is definitely, you have to be able to work together, whether that's your internal staff with vendors. It all has to be a partnership. And for all of your puzzle pieces to lay right together, there has to be that open line of communication. I was at a HFMA conference not long ago, and Jonathan hit on, a lot of the CFOs and what they were looking at. And we were listening to a panel discussion, and they mentioned, in today's healthcare environment, they've gone from even just having a 5-year plan to looking at very strategic and deliberate 2 to 3 year plans that are bringing in the quickest cash for their health organization, helping sustain the liquidity, and then doing what's right for the hospital's financial health. And it can't be just the same old process and routine that they have done historically. So, when we start looking at government reimbursements, again, the concept has stayed pretty well the same. The transfers and the shadow billing and the IME, those have been consistent for, transfer DRGs. We've been in this space for 15 plus years. IME and the shadow billing came into play in 2009. So these are not new issues, but in order for the hospitals to see a change and to be able to increase those dollars, we have to start doing something different. And again, a lot of that is technology based. So when we start looking at a lot of the technology that is here, then we start looking at when we're looking at revenue opportunities and cost reporting opportunities, where do those areas overlap? How can that help increase the revenue? And then what does the timing of the payments on those look like? So we'll start really on that revenue opportunity side. It's a little less complicated when you look at the transfer rules and the IME. Really, what hospitals need most there is the technology support. What data do they have access to that's going to be outside of what's just within their patient accounting system? That's really where partnering with a vendor who is keeping up with those regulations as they change, for the transfer DRGs, where are the RAC audits going on? What are the auditors specifically looking for? Where can we dive deeper into those different areas? That's probably going to be your, I like to say, your fastest cash. If you're looking to clean up some of those processes, look at your data, have an influx of cash. Typically, when we're completing these projects, we would normally see an influx within 90 to 120 days with that quick cash win. But then how do we figure out how to make that streamline going forward so you're not on this constant roller coaster of give me an influx, let's drop it back down, let's get another influx. Same thing happens with the cost reporting opportunities. A lot of providers complete this work in-house because they want to do some cost savings there as far as putting together the cost reports. And then they'll just say, we'll have another vendor come in and, do a secondary run, that safety net approach, further down the road. And really what happens there and why it's so important for hospitals really to focus that is you're shifting your timing of your payment. So the more you can capture right up front and your areas, your revenue cycle is working together with your reimbursement teams as far as data and what opportunities are there and what can be supported. You're typically going to see those payments within a 60 to 90-ish day window on a tentative settlement. And then if you have that secondary vendor coming in and looking at your data again, you're going to shift that payment out to probably 2 to 5 years versus that 60 to 90-day window. So as those CFOs are looking for how do we help with, the financial aspects of our health system, that's probably, I would say, one of the easiest adjustments there. And really looking at your data. So when most of these hospitals are completing this work in-house, they only have access to the data that is within their patient accounting system. They're not always looking at a holistic approach of where else can we find revenue. So normally, when you're working with a vendor that has more technology support, whether that's in a services model or like what FinThrive does, having an actual a SaaS platform technology, we want to streamline those data sets and say, okay, if you're going to put in the work and you're going to get us the data, we're going to give you as much information out of that data that we can. But we're not only looking at your hospital data, we're actually looking at those true source files. So we're getting data from Medicare, from Medicaid, from your collection agencies. We're running eligibility, and then we're taking all of those disparate data sets and we're putting it together in one single location where you really have that dashboard, and you're getting the lift out there. And I mentioned earlier, you have multiple opportunities of, how we can deliver the information back to you. And so there is a strategy there. Jonathan, if you'll go to the next slide for me, when you're looking at how do we consume this data, how do we intake the data, how do we use the data? Again, a lot of the legacy workers or the older workers that have that tribal knowledge are getting ready to retire. So then you start looking at succession planning, and you really have to sit down and think, if we're going to maximize our reimbursement and help fill those gaps, what does that look like specifically for us? We've had hospitals where that gap is, we don't have a succession plan. We need boots on the ground. We need somebody that has the knowledge. We need somebody that can do the work for us. Other facilities that we've worked with, they have started a succession plan. So they're transferring that knowledge, or in a lot of cases, we've actually had a lot of auditors come over, from the dark side, if you will, over to the hospital side. So they have the knowledge. They just need that technology support. So when you're looking at that from a holistic view, a lot of that is, something to take into consideration when you're thinking about your next steps. Jonathan hit earlier too on, we were looking at some of the cost reporting data and visibility that we have. A big topic that has come up lately, and it's really been within the last, 3 or 4 years, we've seen it more and more, but we're seeing that shift from your traditional Medicare beneficiaries that are driving all of your reimbursement there from a bad debt perspective. We are seeing some of the Medicare Advantage population where the demographics are almost 50-50 with your traditional Medicare population and your Medicare Advantage population. So in some cases, And you really want to make sure you work with somebody that has that knowledge and review some of your contract language. But in some of those cases, the areas like transfer DRGs and bad debt, you can still recoup those dollars. So, I know people that have been very set in their ways. Bad debt is only tied to Medicare. We can only file our Medicare bad debt with a cost report. Based on your sample, your language within your contracts and your negotiated rates, there can be opportunity to take that same process and compile bad debt listings and submit those directly to the Medicare Advantage plans who state within their contracts that they will pay similar to Medicare. That is something, again, that we do a lot. We're happy to help review contracts. If you have questions, feel free to reach out to Jonathan or I, and we can help you guys with that. And then also, as you're working with a vendor, you want to make sure not only are we pointing out the things that are going wrong, but how do we fix it? So if you have a puzzle piece that's off, how do we lay out all those puzzle pieces for you? So, your reimbursement is there, you're solid, the direction that you're going. So when you're looking at your reimbursement as a whole across the board, you want to make sure that you have somebody that is giving you that dashboard or those analytics and that view of your data. So it's not just, again, what you can see within your hospital data, but it's globally across the board what we can see using all of those source data. So when you have a reimbursement person come into revenue cycle saying, this is wrong, this is wrong, this was wrong, we got hit at audit, we want to change that perspective where it's not the back and forth finger pointing, but it is that collaborative approach, and we can actually quantify for you, hey, based on the data, this is what it tells us. We have a hospital that we worked with in the Northeast who said, our revenue cycle folks made a decision that they weren't going to bill some of the psych Medicaid secondary patients because they did not feel like the juice was worth the squeeze. They weren't going to get back anything that was substantial. They were already, overworked, didn't have the bandwidth to pick those up. Not a big deal. Medicaid's not going to pay. So we did an analysis of the data, again, using the source data from Medicare, Medicaid. We were actually able to present back to them a story that just based on those crossover patients that were traditional Medicare primary and Medicaid secondary, they were leaving $250,000 on the table by not billing those Medicaid patients. So it's so important to use that full set of data and have that overarching holistic view where we can improve it. But again, if you're going to ask somebody to make a change, you have to be able to quantify that for them. And then also looking at, your year over year trending. And I mentioned earlier the roller coaster of payment timings. And if you're missing something, then you have to go back in and clean it up. And then, you drop back down. And what we want to do is make sure that you're staying at a steady state. So we look at cost reporting data on a quarterly basis. It does break down the 3 buckets of bad debt within our projects there. And even in the cost reporting information, we can see it separately, your crossovers versus your self-pay and your charity. So we really know as we're looking at that delta, we know where the issues typically reside. And then out of that dashboard or those analytics that we showed earlier, we can really show you what was missed, again, quantify the value of that, and then make suggestions on how to fix it. So we're not just going in and pointing fingers or telling you did something wrong, but really from a partner standpoint, how do we make sure that subset of population that you're missing Granted, you cleaned it up and you're going to get money 2 to 5 years down the road. How do we get that current today where you can get your payment in 60 to 90 days versus waiting that 2 to 5 years for it? And I would say that's really, from an annual standpoint, you want to see that you're good, Jonathan. You want to see that how you're missed. But then also, this is just an example of some of our performance reviews for the revenue opportunity. So the transfer DRG and the IME. Same thing here. You want to point out what the team is doing good as they are seeing they're making adjustments to their process. They want to be able to track that and say, we've put in the work. We made this small change that we thought wasn't going to have an impact, but it has completely shifted our revenue, or we have gone from Q1 to Q2, we have almost tripled our revenue based on a small, insight of information that we received and a change to our process. And then just making sure things aren't getting lost in that black hole. So with the transfer DRG and the IME, you get to see more of a real-time feature because you can access some of that information. There's not quite as many moving parts as having to go through Medicare payment and then a Medicaid payment or a self-pay process. It's more real time, if you will. So making sure that none of that opportunity, again, is getting lost in that black hole. You're getting paid timely. Any of the counts that are returning to the provider, again, another learning opportunity. If we start to see trends where a certain rejection code is consistently being hit and returned, those are the things that a hospital needs to see. And then you're moving more to a proactive approach in your revenue versus constantly being in a reactive mode there. And then also, when you're working with a partner, you want to make sure not only are you keeping up with, just policies, regulations. I mentioned it earlier. Not everybody is cookie cutter. So you have some health systems that you see now are starting to acquire facilities in different states. So you're going to have different state rules. You're going to have CMS changing formats on how your detail has to be provided. Some of this information may come from a legacy system. So as you're having system conversions, you're acquiring hospitals from different states, different patient accounting systems. How do you get all of that information down into that single data warehouse where you can pull the supporting documentation that CMS is going to require, and make sure that you're filling in as much of this information to not have the red flags when it comes time for audit. So obviously you have the new bad debt listings. We have new dish listings. We have a team that keeps up with that. That is all they do. They're monitoring those regulations and seeing if there's a change. How do we get with our product team to make sure that is constantly staying caught up, where, some hospitals, if you're already short on bandwidth, that's hard to keep up with and develop. So.
This slide talks about HFMA really pointing out what Amber's saying in terms of how you can get kind of part of the way there versus, all the way there with technology. And this isn't me or Amber. This is HFMA. I'm a big believer in HFMA. I'm going to be out at Western Region next week in Las Vegas with Region 10 and 11. And I'm a region exec for Region 10. And I spend probably a third of my career in HFMA events. Amber and I, as we mentioned, we were out at Region 9 out in the South, which is a heavily Medicare, Medicaid population, looking at what they're doing. And they really talk about just this kind of lackluster performance that's happening with bad debt, uncompensated care, dish, and just having that lack of technology there leaves 10% more in losses, which we just talked about margins and how razor thin those are. And I think everyone, as Amber said, is doing the best they can, but we really are a good to great organization. We want to automate and really get at some of those areas where we can make things better as we move forward. This is a case study here. I'll let Amber kind of give some of the details as well, but $1.9 million we found above and beyond what they normally had found when they were looking at it. And Amber, I don't know if you have things to add on this, but this was a great study from one of our customers.
And I think really this is where you get into using the source data and just being able to have that visibility using the disparate data sets that most hospitals just aren't set up to, consume that amount of data. And then know what to do with it. And so again, you're getting into different areas of the hospital organization working together. So now you're starting to bring in IT as well. If you're going to have support on how to build something out, you're going to have somebody from reimbursement giving feedback and somebody from revenue cycle that's given feedback, and then hope it's not lost in the mix with your IT person who is in SQL or in their IT land and language, trying to interpret what you're trying to accomplish from a finance standpoint. We have time and time again, we continue to see missed opportunity, and most of it is data driven. It's the lack of visibility into your data until it is too late. And then it's a very, again, turf war back and forth. Well, they did this wrong. No, we did this right. You're interpreting the data wrong. So somebody that can come in and help be a stopgap and fill in some of that, data support, that have a knowledge support. So you have a sounding board from an outside source where you can say, hey, this scenario is going on. I need your unbiased opinion. How are other health systems in the market handling this? What are other hospitals within our specific region doing to take care of these issues? And then again, I mentioned earlier your delivery model. And so something that FinThrive is very proud of is we meet providers where they are. So we have, we invest a lot in the technology, but also within the people. So as we're looking at delivery models for providers, you have the option, if you don't have the knowledge base there, full consulting, outsourced, turnkey model, send us your data, we'll analyze it. We look at it from the perspective of an auditor. So things that we want to make sure are going to pass audit. Typically even running behind in a safety net position behind some of the other vendors. On average, we still find about a 30% increase to your revenue. So it's always good. And we have people that run as a safety net behind us. It's just, it's good. You can never, in my opinion, you can never have too many sets of eyes. So even if you have a primary vendor in play, we're happy to help just be that safety net set of eyes. As you have you're looking at that 2, 3, 5-year plan. If you want to groom up your internal people, you have the knowledge base and you want the technology. We're one of the few vendors that actually offer not only from a full consulting model, but we allow our provider partners to actually log into our technology and utilize the same SaaS platform that we do. So we have had some providers who, they have started out in that full consulting model. Their 2 to 5-year plan is we want to move into that SaaS space. They move in, they try it, they don't like it, they want to go back to the outsourcing model. totally okay. I think that's really where you get into that. You find a partner that works with you and has that flexibility to kind of be able to go with the wind for whatever scenario you're facing today as a hospital, whether that's bandwidth, knowledge. You just have so much on your plate. The cost report is inputs, thousands of inputs. And when you start looking at bad debt, dish, and S10, those are the three areas out of those thousands of inputs that require patient level detail. So we have had some of our providers who have said, they had the knowledge, they needed the technology. They've gone from, when you're in your 5-month cost reporting window, where 4.5 months of that, they were heads down in nothing but the bad debt and the dish listings from sun up to sundown, be able to take that analytics dashboard and take that 4.5 months of crazy chaos and consolidate that down to 2 or 3 weeks. And then they're able to focus on other revenue generating projects or learn different areas of the cost report where they can help support other areas, or just the whole financial health as a hospital overall, and also keep their sanity while they're in that cost report mode. And then looking at the synergies, we talked earlier in the beginning, using the data sets, being able to take the enormous amounts of data that we have and provide back to providers the most revenue that can come out of that single streamlined data set. And really, in my opinion, and probably because I've sat on the back end more so, but when we look through these analytics dashboards, a lot of the areas where hospitals are providing are crossover bad debts. Medicaid is not being billed timely. Those accounts are going non-timely before the bills go out the door. When you're looking at an end-to-end platform, you can start really filling in those gaps earlier in the process. So, for example, the Insurance Discover, looking at some of that real-time eligibility and making sure you have the coverage correct when a patient enters the door before their service, whatever the case is, that patient has to be billed to Medicaid. So now not only are you potentially increasing your revenue earlier in the year, but that trickle down effect of your cost report is you're going to see less issues at audit because your timing of bills getting out the door are going to be more accurate. Your billing, your statements that are going out, your charity process, all the things just tend to go a whole lot smoother when you find those holes earlier on. And we did do this is an actual case study where we had taken a facility, a partner where we were looking specifically at their Medicaid population. So with the crossover bad debts, cleaning up some of those accounts that were not billed timely, and then also making sure we found all of their eligibility, whether that's in-state, out-of-state, traditional plans, managed plans. And we were able to increase their revenue by $250,000 a year using the same data sets. So there was very minimal lift from a data standpoint. It was a communication issue that needed to happen. So again, just making sure that communication is there between departments, but then also the visibility. If something's going to change, then we have to change the whole process. We can't stay standard quo and expect the revenue to increase there.
Thank you, Amber. Yeah, I think, double clicking on some of those case studies there at the end, and you guys will get this deck. We'll have it for you. We're happy to provide those case studies from Amber as well, is when I was a chief revenue officer, I think the last thing any of us wanted was a distraction from another vendor coming in and making things more complicated. Cost report strategies, as Amber said, are pretty traditional. I would argue they're probably pretty mature and known. If you look at those case studies, you're seeing a 30% delta from what the existing processes are getting out of Medicare beneficiary bad debt. You're seeing a 15% lift on some of the things that are being found on DISH or the 340B or other areas. And it's a data set that could be leveraged that really is just incrementally delivering a higher level of cash based off of the market that you're in now. And with the shifting strategy of the CFO really being operationally proficient, not only financially proficient, and I would argue compliance risk too, double clicking on that, you saw those numbers, high 90% defense rate, where an auditor comes in, we're defending what we found as a partner at the elbow with you in terms of what types of reporting and documentation that needed to occur to get to that incremental revenue. Like I mentioned at the beginning, CMS doesn't pick up the phone and say, hey, we shorted you. We're going to give you some money. You've got to refile. Whenever you refile, that raises a flag that causes audit risk to come to you. We know that. We prepare for that, and we have our homework ready for when it's there. Everybody's aligned, and the expertise is there, and we can really drive those efficiencies and revenue. Amber, you did beautifully, as I knew you would. We're going to open it up for Q&A now. I think we've got about 10 minutes. Becky, I don't see anything in the Q&A. I might ask Amber some questions if we don't have any from the thing, because I know she's good at everything, but she's probably better at fielding questions than presenting slides. So I'll throw her some curveballs here in a minute if we don't have anything. Amber, where do you see folks finding the most opportunity would be one of the questions I have for you. So when you're on site with a customer, where do you see the conversation kind of hinging or focusing on the most? You're on site today, for example. What types of things did you talk about today?
Actually, the whole gist of the conversation today was utilizing the same data that we have in the scenario. In today's case, it was a provider it's looking like they're going to potentially lose their 340B, which is a multi-million-dollar issue for them. And so it is figuring out what rocks can we overturn? Is there anything else that we could do that we haven't done? And in this case, it was when we work with them to help prepare their dish listings, they actually utilize the software. So we run eligibility, we've rerun eligibility where we have direct connections with the states. The conversation actually shifted though to, you guys are also an Insurance Discover client. So to make sure we're turning over every rock, because our Insurance Discover platform, we're connected to 880 payers. That's a lot of opportunity when you're starting to look at the population. Let's take the eligibility that we got back directly from the state and compare that over to that Insurance Discover, just so we can say no rock was unturned. We are literally looking at hospital data, state data, 835 information, eligibility information, and trying to do everything that we can to help those providers. But then you get into, the communication between the two teams, because today we met with the reimbursement folks, and, some of that support on the Insurance Discover side comes from the revenue cycle people. They're having to go to revenue cycle for some audits that they're currently on. And one of those audit issues was, did the hospital write off to charity too quickly? Are they just assuming that the patient has no insurance and they wrote it off to charity because they didn't want to do anything with it? Again, that's where you can go back into that Insurance Discover and work with your revenue cycle team and just really think outside of the box. How do we use the information that we have to best support the provider when the audit is they're just nitpicking every little detail.
That's great. I don't see any other questions. As Becky mentioned, there's a QR code there. Amber and I's emails are here as well. We love, absolutely adore getting questions from our customers or folks that are interested about this. As dry as cost report is, Amber and I love talking about it, and we love talking about government reimbursement, and most importantly, we love delivering cash where it's due and understanding how we can help you get there. Amber, thank you so much. Becky, thanks for hosting us.
Thank you.
Thank you all for being on the phone today. If you have any questions whatsoever, feel free to zip us an email, and there's a QR code there. And Becky, we'll turn it back to you, and thank you so much.
Awesome. Thank you, Jonathan and Amber. That was a wonderful presentation. And thank you all for joining us today. Thank you all again and have a great remainder of your day. Take care.